Thank you for being here, and thank you for being part of the first annual Autoimmune Encephalitis Week. We've got lots of events going on. I'll tell you about a couple of those. But I want to say, first of all, again, I'm Will McDowell. My wife Leslie is sitting in the front row here, along with Helen and Daniel Egger. We're the co-founders of the Autoimmune Encephalitis Alliance, a nonprofit based here in Durham. But what's so exciting about this week is that we've got doctors from around the world, 25, 26 clinicians and researchers in town to really begin to think about how do we achieve the mission and the vision of the Autoimmune Encephalitis Alliance, which is to find a cure for autoimmune encephalitis accessible to all. And that's a story that if you talk to families like ours, like the Eggers, like Susannah's book tells, it's really folks struggling to find out how to diagnose, how to treat, and then how to get through recovery of this disease. And Susannah's going to tell us, Dr. Najjar going to tell us more about that. But I want to really emphasize, we're an organization that's a year old, and here we are really doing something that I hope is going to be momentous for changing the trajectory of this disease, that you'll hear more about in a few minutes. Again, we've got big plans. Tomorrow there are going to be lectures, grand rounds, and some panel discussions at Duke. They will be open to the public. Those are mostly in the morning. If you're interested, see one of us afterwards. And then kicking off in the afternoon and running through Friday is the first International Symposium on Autoimmune Encephalitis, where we'll really get the brain trust together to help us figure out how to go about this disease. So a lot going on, really exciting. If you haven't seen it as you came in, we do have some information on the front table. Feel free to grab those. If you haven't read Susannah's book yet, we have copies, signed copies for sale here as well afterwards. So thank you again for being here. Let me do a quick introduction, though I'm not going to do a lot of introduction because I think they'll both talk for themselves better than I can. But Susannah Cahalan is a journalist, but she's a medical writer. She's also a survivor, and she's going to talk a lot about being a survivor of autoimmune encephalitis. Susannah is also on the board of the Autoimmune Encephalitis Alliance, and is really the connection that brought much of us together. And we had the Florence 4th Road Race that many of you were part of. At a lunch afterwards, it was amazing the stories of the families, and they almost all went back through Susannah somehow. And so she's been an amazing voice and face for this disease, and thank you for being here. After she speaks and kind of tells about her experience, Dr. Najjar is going to get up. And Dr. Najjar is an associate professor of neurology and neuropathy at NYU Medical Center in New York. Dr. Najjar graduated from Damascus Medical School in Damascus, Syria, and has an amazing journey to where he is now as well. Dr. Najjar is part of the science advisory panel of the Alliance and provides great service to us there. So, and tonight he's going to describe how he diagnosed and treated Susannah, which was an amazing story. So without further ado, I'm going to invite Susannah to come up and tell us her story. So thank you, Susannah.
I don't think I ever could have imagined this week, prior to this week. I always wanted to be a journalist, and you want to be a journalist for a variety of reasons, but I think good journalists want to be journalists to help other people. And I never could have dreamed the impact that this book has made on other people's lives. I just spoke to a family today, and they got something from it. And I got to meet these incredible families. I got to meet the McDowells, who are just remarkable and resilient and strong and like Energizer Bunny kind of amazing work ethic that I've never ever seen before, and the Eggers, who are just brilliant and warm and so inspiring. I mean, all of you guys are just inspiring people, and I just feel so lucky. I feel lucky that I got this disease, because I know that sounds so bizarre, but it's brought me here, and it's brought me with all of you. So anyway, I'm going to go through, I don't know how many of you have read my book, but I'm assuming a lot of you already know my story. But I will go through the motions anyway, and hopefully you'll enjoy it. Enjoy maybe isn't the word, but This all started in 2009. I was 24 years old. I had recently moved to New York City, living on my own for the first time in Hell's Kitchen, working as a reporter for the New York Post, a general assignment reporter, meaning that one day I would be stalking Alec Baldwin, which I did around that time. He was even crazy then, in 2009. And then the next day I was doing jailhouse interviews with kidnappers in prison. So it was a very strange, unnerving, fun, exciting time. But I think one that was, so new and exciting that I think it took me a long time to realize that there were all these new things happening internally. So the first thing that, where I trace it to the beginning, and this is only after the fact, this is after having looked back. At the time I had no idea where this was beginning, but I kind of trace it back to the time when I thought I had bed bugs. And again, this is 2009 in New York City, and everyone thought they had bed bugs. So again, not that scary in itself, but my reaction and my normal personality, that's why I begin it there, because I am not a histrionic person. As Dr. Najjar knows, I don't run back to doctors. I should go to doctors more often. I'm not. But this case, I had 2 bites on my arm that were probably spider bites, but I became obsessed with these bites, believed so fully that my house was kind of infested with bed bugs that I hired an exterminator to come in and take a look at my apartment. And even the exterminator told me, I don't think you have bed bugs. And I was like, you're exterminating anyway. And $2,000 later, had to do that whole crazy thing. And that's the beginning. And again, but that's not gonna kind of push you towards a doctor or towards a hospital or even towards a psychologist or psychiatrist. And even what comes next didn't either. So I had just started dating my boyfriend. His name's Steven, and it was about 4 months before. And he had left me in his apartment in Jersey City. And I was compelled, kind of overwrought with this urge to go rifling through his things, which was, again, I really think is outside of my personality, I hope. And so I felt the compulsion was so strong that I just kind of ripped through all of his things. I started with his email, went through all of his private letters and anything I could get my hands on. And at one point, as I reached for the next letter, I caught sight of myself in the mirror of his armoire, wearing only a bra and underwear, clutching Stephen's private love letters between my thighs. A stranger stared back from my reflection. My hair was wild and my face distorted and unfamiliar. I never act like this, I thought, disgusted. What's wrong with me? I have never in my life snooped before through a boyfriend's things. I ran to the bed and opened my cell phone. I had lost 2 hours. It felt like 5 minutes. Moments later, the migraine returned. At this point, I had started having pretty bad migraines, which had never happened before, as did a feeling of nausea. It was then that I first noticed my left hand felt funny, like an extreme case of pins and needles. I clenched and unclenched my hand, trying to stop the tingling, but it got worse. I raced to the dresser to put away his things so he wouldn't notice my pilfering, trying to ignore the uncomfortable tingling sensation. Soon, though, my left hand went completely numb. The left hand numbness for me was something very scary. So all these kind of other signs didn't send me to a doctor, but one-sided numbness was scary. And I went to a doctor, and after doing routine workup, he found slightly enlarged lymph nodes in my spine, which led him to believe that I most likely had mono. So that was my diagnosis. I was very tired. I was flu-like. I had trouble concentrating at work. So it made sense. That is, until about 2 weeks later, when these flu-like symptoms actually started to go away, and I actually felt a lot better. But I felt better in a very different way than I didn't feel normal. I felt better, but not normal. So I want to describe for you kind of the moment where I realized that something was really wrong with me. I didn't know what was wrong with me, but something was really wrong with me. And it was after I really badly bungled an interview with John Walsh from America's Most Wanted, where he would talk to me and I could understand what he was saying, but I couldn't translate his words to the paper. So I couldn't actually write them down. So what I did was I pretended to actually interview him and wrote down random words instead. And luckily that article never ran, which is a testament. When my editor was reading a copy of this book, he said, "Please tell me that story didn't run." I was like, "It didn't." Anyway, so the next morning, after a night of insomnia, this had been several nights of insomnia now, it was a gorgeous early March morning, the sun was out, and the temperature was a crisp 30 degrees. I had walked through Times Square twice a day for 6 months, but today, once I hit the rows of billboards at its center, I was accosted by its garish colors. I tried to look away, to shield myself from shockwaves of pigment, but I couldn't. The bright blue wedge of an Eclipse gum sign emitted electric swirls of aqua and made the hair on the back of my neck stand up. I could feel the colors vibrating in my toes. There seemed to be something exquisite about that rush. But the thrill only lasted a moment when to my left the moving scroll of welcomes you to Times Square caught my attention and made me want to retch in the middle of the street. M&Ms on an animated billboard pirouetted before me. Helpless in the face of this onslaught, I covered my eyes with mittenless hands, stumbling up 48th Street as if I had gotten off a death-defying roller coaster until I hit the newsroom, where the lights still felt bright but less aggressive. I turned to my colleague at that point and I started saying things like, I think I'm going crazy. I think people are listening in on me. I started sounding very paranoid. And this really started to concern my colleagues because everything else I've complained about headaches and not feeling like myself, but this was the first time I was saying something that was really unsettling. And then I would just start crying for no apparent reason. It was very disruptive to the newsroom, as you can imagine. And I have no idea what they thought was going on because it's a room full of reporters. But so I want to describe a little bit of what it feels like to go through a manic depressive episode in the matter of seconds, as opposed to kind of rapid cycling bipolar disorder happens over months. This was happening to me over seconds. So I want to kind of describe this for you. As the crying spell took over my whole body, I became prisoner to it. The more I told myself to stop, the more powerful the sensation became. At that point, I started to think about what could cause this. Was it my boyfriend? Was it my job? Was it this? Was it that? And I was trying to figure out what was making me so upset, but I couldn't actually pinpoint it. But then a moment later, the tears would continue down my face, but I was surprised to realize that instantly I was no longer sad. I was fine, happy. No, not happy, sublime, better than I had ever felt in my entire life. The tears kept coming, but now I was laughing. A pulse of warmth shot up my spine. I wanted to dance or sing something, anything, except sit here and wallow in imaginary misery. I ran to the bathroom to splash some water on my face. As the cold water flowed, the bathroom stalls suddenly looked alien to me. How was it that civilization had gotten so far, but we still defecated in such close proximity to one another? I looked at the stalls, and hearing the flushing of toilets, I could not believe that I had ever used one before. I learned later that that was the opposite of déjà vu, jamais vu, where everything suddenly looks alien, strange, sinister kind of. And I remember asking a friend, telling a friend this was going on, and she said something to me that was so prescient and something that I remembered while writing my book, it was an important kind of guide for me while writing my book. And she said to me, I'll read it exactly, she said, write everything down. Don't leave anything out. As you know, even the smallest details can turn out to be the most important. And that would be key later when my Dr. House would enter. But after that, I had my first seizure. And at that point, my editor, my friends, were all kind of speculating that I was going through a nervous breakdown or some kind of break. But the seizure didn't really match that idea. But I'm going to just read this scene. And this I call a scene because I don't remember any of it. And that's from this point on pretty much characterizes the book. Besides my hallucinations, after this first seizure, much of my memory is lost. So I actually had to rely on other people to build a narrative. So this is from Stephen's perspective. As Stephen later described that nightmarish scene, I had woken him up with a strange series of low moans resonating among the sounds from the TV. At first he thought I was grinding my teeth, when the grinding noises became a high-pitched squeak, like sandpaper rubbed against metal. He knew something was wrong. He thought maybe I was having trouble sleeping. When he turned over to face me, I was sitting upright, my eyes wide open, dilated but unseeing. "Hey, what's wrong?" No response. When he suggested I try relax, I turned to face him, staring past him like I was possessed. My arms suddenly whipped straight in front of me like a mummy as my eyes rolled back and my body stiffened. I was gasping for air. He called 911 and somehow magically knew that this was a seizure, though he'd never seen one before, and placed me on my side. I woke up in that hospital a completely different person. I was going to sue the doctor for all these various bizarre reasons that made no sense. I was screaming and carrying on, and that paranoia followed me after I got out. So at that point, my mom collected me. She took me to her house in New Jersey, and we went back to the same neurologist who said I had mono, this time with seizures as a symptom and kind of strange behaviors as well. I'm not sure if I had communicated at all that light sensitivity, that photophobia, but definitely my mom was telling this doctor that she is acting paranoid and very differently than she normally does. The first diagnosis that I received from that doctor after mono was then alcohol withdrawal. And he was very certain of this to the point where we returned twice more after that. And he was very adamant about that. And she kept saying, "This doesn't make any sense. It doesn't make any sense at all. I have not seen her drink at all since this." And in fact, when I later got my medical records, I saw he had asked me, "How much do you drink a day?" I said about 2 glasses of wine per night. And he had written down 2 bottles of wine per night, which completely had shaded the way, I think for a period of time, the way following doctors kind of viewed me and my lifestyle. But it was clear that I was not all acting in my right mind when my mom took me back yet again for another EEG, because nothing was showing up on the EEG as well. So again, all these tests are coming back normal, but I'm getting worse and worse and continuing having grand mal seizures and probably kind of staring episode seizures as well. So I'm going to just read this section a little bit. Okay, so this is on the way to the EEG. So we had to drive from Jersey through Chinatown, which is an unpleasant trip, but even more so when you are hallucinating. When I opened my eyes again, we had exited the Holland Tunnel and were entering Chinatown with its sidewalk fish, swarms of tourists, and fake designer bag salesmen. The whole sordid scene disgusted me. At this point, I started screaming, "I want coffee." I was demanding coffee. I tried to jump out of a moving car. I was hearing my stepfather call me bad names. I mean, I was devolving very fast. So my mom took me in, and I remember walking into the neurologist's office. It was on the Upper East Side, a very fancy office, and there was a Moreau painting on the wall. And I remember it was a face with eyes, but the mouth was outside. It's a really bad picture to have a neurologist's office. The mouth was outside of the eye, and there were all these, those all primary colors. It was very, very sinister. I remember staring at that Moreau and understanding it in such a deep way. So I'm at the EEG, and now this is completely an unreliable narrator. At this point, don't trust me at all, because I don't know if I'm saying it actually happened. But this is how I remember this happening. She did the EEG test, and anyone who's familiar with that, you do a lot of breathing and counting. And so after the breathing and counting and the strobe light and everything, she said, "So are you a student?" And I said, "No." She said, "What do you do?" I said, "I'm a reporter. I write for a newspaper." She said, "Stressful, huh?" And I said, "Sure, I guess." And then she said, and again, unreliable narrator, "There's nothing wrong with you." She said, gathering the electrodes back into the box. "I've seen this dozens of times, mostly with bankers and Wall Street guys who come in here all stressed out. There's nothing wrong with them. It's all in their heads. It's all in my head." When she closed the door behind her, I smiled. That smile turned into a belly laugh, dripping with bitterness and resentment. It all made sense. This was all a ruse set up to punish me for my bad behavior and tell them that I'm suddenly cured. Why would they try to trick me? Why would they arrange something this elaborate? She wasn't a nurse. She was a hired actor. My mother was the only person left in the waiting room. My stepfather had left to get the car, and Stephen, overwhelmed by my harrowing behavior on the ride in, as in trying to jump out of a moving car, had called his mom for consolation and advice. I gave my mom a wide, toothy smile. "What's so funny?" she asked. "Oh, you thought I wouldn't figure it out. Where's the mastermind?" "What are you talking about? You and Alan set this all up. You hired that woman. You hired everyone here. You told her what to say. You wanted to punish me. Well, it didn't work. I'm too smart for your tricks." My mom's mouth fell open in surprise, but my paranoia read it as nothing more than mock surprise. So at this point, my mom shipped me off to my father because I was an insomniac too. And just one day, she woke up to me standing above her bed, just staring at her. She said, "I need some time without this person in my life." So she sent me to my father's house, and which probably wasn't a good idea either. Me and my father were not in a great place then. Now we are, but so I think anyone who's going through paranoia and psychosis, don't change their environment if you don't have to. But I was at my dad's house. And at that point, I had full-on hallucination where the pictures came alive. My dad he's an avid war collector and has guns and swords and busts of Abraham Lincoln. Like, I'm not even kidding. And Abraham Lincoln eyes started following me, and like the Declaration of Independence signing, like people were moving in it. And then I heard my dad beating my stepmother, and I was so certain that he was doing that. I could hear his fist hitting her. I could hear it as I'm hearing anything in here, as clear as day. And I ran to the bathroom, barricaded myself in, and almost jumped out the window. But my stepmother keeps a Buddha by the kitchen sink, and the Buddha statue smiled at me. And so I said, "I'm not going to jump out the window." And it was because of that Buddha statue that I'm here today, I think. After that, they were like, "You have to go to the hospital." And my mom was adamant that I not be placed in a psychiatric hospital. I think the seizures really were the clue for her that something was wrong, and she wanted me in the hospital. And she fought the doctor, who was still very adamant that this was alcohol withdrawal. And she fought him, and finally he said, "Well, NYU has 24-hour EEG monitoring. We can try to get her in there." He calls. They happen to have one bed open. We go to admitting, and anyone in here who's been in a hospital admitting knows that's a long wait. Usually you don't just get ushered in. I had a seizure in the admitting area, which is the best place. If you're going to have a seizure anywhere in the world, have one at NYU admitting area. And then so I was ushered up, and at first I was placed in a AMU, a 4-person AMU room, which was also really bad for someone who's psychotic to have that many people around you. And that was at the height of my psychosis. And I'm just going to read just one of my hallucinations. There were a few that I remember during that time, but I'm going to read one. This is after probably two escape attempts, like 2 hardcore escape attempts, like almost made it to the exit sign, had to get, tackled and sedated and stuff. So this poor, wonderful woman, Dr. Khan at NYU, she's still there, right? Yeah, she's wonderful. And she was a really good sport about all this because I saw her after the fact. So I'm going to read my experience with her. So she walks in, she's a psychiatrist or a psychopharmacologist. Yeah, psychopharmacologist. And she walked in, and immediately I said to her, "I have multiple personality disorder." And she nodded and said, you thought in her head, like, "You have picked the most, controversial diagnosis in the field of psychiatry. This is probably not it." But she asked, "Have you been diagnosed by any psychiatrist or psychologist in the past?" I said, "Yes, a psychiatrist said I had bipolar disorder," which wasn't entirely true, but it wasn't untrue. Around the time when I was going to that neurologist who said I was suffering from alcohol withdrawal, I went to a psychiatrist who gave me antipsychotics and was I have her medical records, leaning towards bipolar, but wasn't sure. I only saw her once, so I didn't get a confirmed diagnosis. And were you taking any medication for that, she asked. I said, "I refuse to take it out. I spit it out. I need out of here. I don't belong here. I belong in a psychiatric ward. I belong in Bellevue. It's not safe for me here." "Why is it not safe for you here?" And by the way, I got all this from the medical record, which was actually kind of fun to read in a bizarre way. "Everyone is talking about me. They're all talking about me and making fun of me behind my back. I belong in Bellevue where they can take care of my disorder. I don't know why I'm here. I can hear what the nurses are saying about me. I can hear their thoughts, and they aren't saying nice things. Dr. Kahn wrote down paranoid ideation. You can hear their thoughts, she repeated. Yes, the whole world is making fun of me. What else can you hear, she asked. The people on the TV are talking about me too. Dr. Kahn wrote down ideas of reference. And she said, do you have any history of family members with mental illness? And I said, I don't know. My grandmother might have had bipolar disorder. She did not. But they're all crazy, I laughed. Then I turned on her. Then I insisted that I could sign myself out, and there was a whole drama there. But so she wrote down her differential diagnoses, which included mood disorder not otherwise specified and psychotic disorder not otherwise specified. She was concerned that in light of the seizures and my history of melanoma, I have a history of melanoma, they should be looking for neurological causes. If there was no underlying disease that could explain my sudden psychosis, she suggested bipolar 1 as a possible explanation. Now, that's what she recalls, and that's what the medical records say, but what I remember from this is the following. Her skin is so smooth. I stare at the doctor's cheekbones and pretty olive skin. I stare harder still. Her face swirls before me. Strand by strand, her hair turns gray. Wrinkles, first around her eyes, and then around her mouth and across her cheeks, now line her entire face. Her cheeks sink in, and her teeth turn yellow. Her eyes begin to droop, and her lips lose their shape. The striking young doctor ages right before my eyes. I have a gift. I can age people with my mind. This is who I am, and they cannot take this away from me. I am powerful, stronger than I have ever been in my life. So most of my hallucinations were not empowering, but there are some that I understand now when people say that in some of these diseases there's hyper-religiosity. I think that was the closest I got, besides the Buddha statue. But that was this feeling of having a gift, having this kind of ability. But it quickly devolved from there, and again, this is all blank to me because I don't remember any of this. But at this point, all of my blood tests were coming back negative. So, we had infectious disease panel, autoimmune panel, all negative. There were slightly enlarged white blood cells in my spinal fluid, but not enough at the first time to think it was other than kind of a byproduct of the actual test itself. There was some clue, but nothing was confirmed. CT scan, MRI, all normal. But I was getting worse. At that point, new diseases, new symptoms had started to crop up, and I'm just going to quickly read that a little bit. My mother had arrived mid-morning to find that my slurring of words had worsened so considerably that it was as if my tongue was 5 sizes too big for my mouth. This scared her more than the hallucinations, the paranoia, and the escape attempts. This was measurable, consistent change, but in the decidedly wrong direction. My tongue twisted when I spoke, I drooled, and when I was tired, let my tongue hang out of the side of my mouth like an overheated dog. I spoke in garbled sentences. I coughed when I drank liquids, which required that I drink water out of a cup that dispensed only a tablespoon at a time. I also stopped speaking in full sentences, moving from unintelligible ramblings to monosyllables and sometimes just grunts. So this is what I looked like when the doctor who was heading my case had given it up. And my mom he actually walked by again, this is all my mom's perspective, but he walked by my hospital room and didn't come in and didn't do his morning rounds. And she, runs out and says, well, what's going on? And he said, I don't know. We don't know what's going on, and I've given up the case. And he didn't say that he had privately gone and spoke to a man named Dr. Souhel Najjar, who would end up being someone my mom would refer to as Dr. House. And he had this history of actually treating people who, for example, with intractable epilepsy and doing brain biopsy and finding evidence of inflammation and treating them, with anti-inflammatories and IVIG and plasmapheresis. And so he had this reputation as this kind of man to go to when things didn't make sense. And so he had privately called him in, though did not tell my mother at the time that this was happening. So then one day, sitting there was kind of just nothing was coming back, no positive news were coming back. the nurses started kind of talking about this man named Dr. Najjar, and then one of the other doctors started saying, Dr. Najjar is going to come, and we have a bet going on what it is. And so we started hearing this mythical Dr. Najjar, and so finally, 3 weeks into the hospital, Dr. Najjar arrived, and I want to call Dr. Souhel Najjar up now to continue the story.
Thank you very much. I don't know if I could match that, but I'm going to tell you exactly really what happened. So some of it, we hear it, Susannah, the first time around, but it's okay. So for the first 2 weeks, I heard about the case, and we're talking, and I asked the ward attending just to start the IVIG, and nothing worked. She's still not doing badly, and I guess your mom insisted at one point that I need to show up. So what I got from the floor, this is the patient. We suspect probably some kind of drug abuse to some extent, maybe alcohol. And she came in and shortly became psychotic, and she had a seizure. And nothing really unusual about this case. And your IVIG did not work. And so there's nothing much you could do. Aside from what you can know about the first time around now, the complaint that I'm getting it from the nursing staff. Nursing staff have strong lobby everywhere. Don't just cross nursing staff. So Susannah did not make my life easier because she tried to escape twice from the floor. The nurses tried to tackle her. She bit them and hit them, and then about to be hit by the nurse supervisor on the floor in neurology. She does not belong here. So anyway, I came to see her on the floor. And I got really different pictures here. So I walked in her room. She's severely catatonic. And I could understand why doctors would not walk in the room, because he felt she can't even communicate. She's slow and mute, sitting for long hours. She could sit in the same position. And globally confused and impaired, barely could answer very simple questions intermittently. And what struck me about her, that she has significant change in heart rate and blood pressure. She's on triple antihypertensive medication, and sometimes blood pressure go to 190 systolic, and they go next time to 110. And I'm talking to the internist, well, how do you explain this? He said, well, Souhel, sometimes you can't really explain it, but I spoke to a psychiatrist. She's on a triple antipsychotic drugs, and that could cause fluctuation in blood pressure, especially heart rate. Yeah, that can happen, but I'm not buying it. I have a lot of people on antipsychotic drugs. They don't do that. I said, well, how about the seizure? Why we think this is psychiatric illness? Well, the psychiatrist's position, well, Souhel, welcome to what we call first episode, schizoaffective. First episode psychosis. I say, okay, how about the seizure she had? Well, there was some question about some kind of withdrawal, maybe some drugs. How about the CSF abnormalities? They have like around 15, 20 cells. Well, after seizures, you get CSF pneumocitosis. So damn it, no matter what I said, there's always explanation, because there was a true unwillingness to attribute it to neurological etiology. And so the question, when I'm talking to her parents, the first symptom she described to numbness on the left side of her body. That was a clear-cut unilateral, and left-sided, went for a week or two, unexplained. So I said, I have to convince first. I'm convinced it's an autoimmune process. Indeed, when she reviewed the record, she saw my notes, like half a page, but all I said, those symptoms, patient came in with the prodromal-like symptoms, then developed acute psychiatric symptomatology, followed by seizure, reduced level of consciousness, at that time really catatonic, and have autonomic changes. Basically, there's nothing else except autoimmune encephalitis. And I put differential diagnosis, one of them NMDA, but among others, basically everything have to be done. But again, you have nobody believe you on the floor that this is what it is. She's acting severely really psychotic, and everybody worried about her being even on neurology, really floor. So the infectious disease, you say, well, I can't rule out infection, does look like, but you know what, everybody worry about using any strong immunosuppressive agent and somebody look purely psychotic and worry about compromising her from the immunotherapy standpoint with that definitive diagnosis. So the clue she gave me at the beginning, her parents, that the fact she had numbness on the left side of her bodies. So that's for non-medical audience here. Suggests probably involvement on the right hemisphere, parietal lobe, which controlled the numbness on the left side. So I sat with her. We communicate barely, simple questions, barely she could answer, and I have to wait too long, and a lot of times doesn't make any sense. But I said, you know what? I gave her a piece of paper and pencil, and I told her to draw a clock. I have to explain so many times. And she had to try to do that so many times. It took her a while. But eventually, when she did it, that's what she did. She squeezed all the numbers on the right side of the clock face. And no numbers were on the left. I mean, we do that usually for people who have stroke or we have people who have dementia. But I have not seen anything like this or close to that degree. Usually you get some neglect on the left side, but not as dramatic as this one. So remember, her symptoms, the onset, were on the left side. Before even she became psychotic, before she got any mood changes, it was pure isolated symptoms. And now I have this neglect. And again, for the non-medical people, what that means, the right side of the brain, especially parietal areas, allow us to perceive, recognize the left side of the space, of the visual field. So with the pathology in this particular area, Susannah behaved as if the left side of the visual field or the space is non-existent. So I know this, the pathology specifically, not only globally diffusely, but more on the right side, and probably started on the right side, because that was her symptoms early on. And based on the fact every testing was normal, as they show, the MRI, to include hippocampi, which is the middle part of the temporal lobe involved in the emotions, was normal. The cortex was perfectly normal. The MRA was normal, the blood vessels, and all the labs was normal to include full-blown paraneoplastic panels. We did it, and that was normal. Chest, abdomen CT, pelvic sonogram, whole body FDG PET scan to rule out occult malignancy that could explain that, and that was really negative. So with this finding and the fact that suggests right-sided involvement, the onset of her symptoms is right-sided, we need to treat her with strong immunotherapy. We're losing her, and I think now in retrospect, she was on the last phase of an anti-NMDA autoimmune encephalitis, where you became basically not just severely catatonic, but potentially have severe autonomic changes to include central hypoventilation and maybe cardiac dysrhythmia, and that's where people could die sometimes suddenly. So we decided to do the biopsy from the right side of the brain because that's where the pathology suggested, at least early on, involvement of the right hemisphere, to prove that this is inflammatory disease, it's not psychotic disorders, it's not drug withdrawal, and it's not infectious, and there's no contraindication, obviously, to use strong immunotherapy. So this is really the biopsy, and this is the blood vessels, and you see those dark cells, dark nuclei, those collection of lymphocytes around the blood vessels. And when you stain for the inflammatory cells, we call leukocyte common antigen, intense perivascular cystic infiltration and sporadic throughout the brain tissue. And that's a stain for the T cells. So there are a few T cells around the blood vessels, and that's staining for macrophages and as well as microglia. And also you see intense staining around the blood vessels, plus sporadic cells positive for that cells. So, and this is the staining for scarring cells, GFAP, and that's blood vessels here, and you can see those spiders throughout the brain tissue. So this is inflammatory disease. Doesn't tell us what it is, but there's no evidence of infection. There's no CMV, there's no opportunistic infections, and this is not psychiatric illness. That's a truly inflammatory disorder of the brain, non-infectious and non-paraneoplastic. So by default, you're left with autoimmune, and now you have to take a shot. And as I said, at that time, she was really, really sick. Around the same, within like a week after this, we got a week or 7, probably close to 8 days, 9 days, from Dr. Dalmo, the result that NMDA positive in the CSF as well. So she already received the IVIG at the beginning, and she was really progressing. We added to that steroid, high dosage steroid, and then plasmapheresis. And then when I met with her parents, I told her that, we have 80% chance that basically we could get her much better. I didn't tell her it will be like 100%, but at that time everybody will take it. It will take the 80%. That is really great sign for improvement. And needless to say, she's where she is right now. We did not have to use rituximab, and the only thing we have to use really steroid, IVIG, and then plasma exchange. And Susannah's going to talk more about recovery. But before I talk about really the recovery and things, it tells you in a major academic institution where she gave us a lot of clues that this is really an autoimmune encephalitis. We were unwilling to believe it is an autoimmune encephalitis. We tried to find a reason for each findings as not neurological. And took like 4 weeks, right? 4 weeks eventually to make that diagnosis, and she was really terribly sick. That was the very first case at NYU, and I guess in New York, probably the second case. One case was probably in Colombia. Nobody had seen it before, recognized the pattern and the clinical. And I know through Dalma group also they did a couple of brain biopsy. The findings really similar. I know he looked at complement staining was negative, also here negative. So she was terribly sick, but the inflammatory response of the brain is not that bad compared to other type of autoimmune encephalitis, like anti-GAD, where you see tremendous amount of real inflammation, in contrast to the anti-NMDA receptor. So anyway, so this is especially, we heard about it this morning. It is an antibody IgG immunoglobulin class directed against specific receptors in the brain called NMDA receptors that are widely distributed in the brain and most in hippocampine frontal region. In hippocampi, those areas responsible for memory, learning, emotions. No wonder why she has major neuropsychiatric features and early on with the mood and anxiety and so forth. And with the frontal lobe involvement, obviously, that's responsible for the cognition and personality, and that explains the severe cognitive impairment that she had and the personality changes that she had early on. With NMDA receptors, it is a complex protein, really. It had multiple subunits. In this particular disorder, the subunit involved is NR1 subunit. And this is the complex of NMDA receptor, has multiple subunits. It's tetramer, it must have 4 subunits. 2 of them mandatory NR1 subunit, and the other one could be NR2 commonly, or NR3, or could be the combination. So that disease is first described, as you know, with Dr. Dalmo. In 2005, he had, I believe, 4 or 5 cases, all related to ovarian teratoma. And after that, 2007, he described the first 100 cases in the world of anti-NMDA receptor encephalitis. And this is just to show you the comparison of Dr. Dalmo's and his group, again, still between 2008 and 2013. So the mean age average was 23 in 2008 paper, is 21. Well, it's now probably even lower than that, because now we see it in 2-year-old. We have one case actually in New York City, 18-month-old, and I think you're aware of it, Susannah. The family you referred to me is well presented with movement disorder, actually. And the female predominant, obviously, and in part also because of the ovarian teratoma. And the prodromal phase, it's a flu-like symptom like what Susannah presented, the fever-like illness, a little bit photophobia, light sensitivity, muscle ache, and so forth. Now, the issue, nobody knows what that prodromal viral illness Is that mean disease, there's something happening, like let's say occult malignancy that never developed eventually, and the immune system, trying to fight the immune system, and in that setting you got some kind of non-specific symptoms? Or actually there's some virus that basically open up the blood-brain barrier and they trigger more of those antibodies? Nobody knows. But reality is 70% of those cases have this. And the reason why I think that's important, not just necessarily occult malignancy, how about other occult malignancy that have autoimmune encephalitis? They don't necessarily have that prodromal phase. That is very common. So again, nobody knows. Personally, I believe there may be something else, some kind of transit virus that open up probably blood-brain barrier and they trigger that autoimmune response in somebody's genetically predisposition. And why I'm saying that, if you look in 2008, look at the association with the neoplasm. It was around 59 to 60%. Now, 2013, 38%. So we start seeing more cases idiopathic without really occult malignancy. Part of the association with the tumor, especially teratoma, it has neural tissue similar to the brain, has NMDA receptor, to some extent similar to the natural NMDA receptors in the brain. So in the process of body try to fight the abnormal neoplastic neural tissue in the teratoma and the ovary, those antibodies cross-reactive with the normal NMDA receptors in the brain and cause that disease. But now we know the majority, they don't have it. Are we saying all those majority have occult malignancy that never developed? I'm not sure that's the case or not. Some of them maybe yes, but others could be other triggering relief factors. And as you can see, majority of the patients initially present to psychiatric illnesses. And as in Susannah, the same case, 77% present with psychiatric. But to have isolated psychiatric illness without other neurological symptoms, probably rare. Although in relapses, very common, it's not uncommon, let me put it this way, that patient present with more isolated psychiatric symptoms. But the initial presentation, it can be early on, pure psychiatric, but later on, you're going to develop some neurological findings. They don't have to be seizures, you know. Seizures could be missing in 20% of the cases. But with good neurologic exam, you can pick up some dystonia, some movement disorders to tell you this is not a pure psychiatric illness as Susannah really developed. Catatonia in 40% of the cases. And obviously people die from central hypoventilation eventually or cardiac dysrhythmia. This antibodies, as I said, when we talk about diagnosing is a simple test now. You could get it in less than a week and commercially available. And the best clue for that disease is taking good history and a clinical examination. Because MRI can be negative in 50%. CSF in Susannah was 10, 15 cells, you know, and you could attribute it to the seizures. And now we know EEG abnormality can be a clue. So in that disease, we find something called delta brush, which is a big slow wave delta. On the top of it, small tiny waves. So appear to be more characteristic, although not diagnostic, but more characteristic for this type of disorders. And the treatment, like what we did, this is the first line treatment Susannah got and recovered fully. And in case she did not respond to that treatment, that would have been obviously the second line of immunotherapy, which everybody, especially back then, would be hesitant to initiate any of those treatments if everybody labeling her as psychiatric, labeled as new onset schizoaffective disorders, bipolar manic disorders, and hard to initiate this treatment back then in anybody labeled with that really disease. So luckily we did not have to use any of those really medications. With that, I'll stop. Thank you.
Susannah and Dr. Najjar would love to take any questions that folks may have.
Do you have any? Well, you know, before we take questions, though, I just want to talk a little bit about recovery, which is something that when I do readings, I don't talk about, depending on who's in the audience, because I was just saying before, it's kind of not, recovery is quieter. It's not as sexy as going crazy. It's a quieter, step-by-step, and it was the hardest part of the whole disease for me was actually the recovery. So, and it was the hardest part for me to write about and the hardest part for me to live through. And so I just want to just talk a little bit about that process. I'd say, it took a month in the hospital for me to be diagnosed, probably a month of symptoms before, if I started with that bed bug, which was February, and then I was hospitalized in March. But after my diagnosis in April, I returned to work 7 months later. But I was not ready yet when I would return to work. I mean, when I had gotten out of the hospital, I couldn't read or write, and I could hardly walk on my own. But I went back too soon. I went to work way too soon, and my newspaper was so nice to me. They knew I was not ready. I really couldn't even take notes that well, so I had to record all of my interviews. They gave me like really easy stories, like hottest bartender in New York City, and it was really nice of them. And then, like my editor sat with me, like teaching me who, what, where, when, and why, and how to write a lead, and all these things that I had known prior to this, but he kind of retaught me all these things. And so I would say that to really feel in my skin again, like, you and, well, I changed his name in the book, but my psychopharmacologist would ask me every time I saw him, what percentage are you back? What percentage do you feel back? And I would always say either 90 or 100%, always, even when I was so far from that. And my mom would have to say, I don't think you're there yet, I don't think you're there yet. But there was a point when I was at a wedding, and my cousin, who I hadn't seen in a while, and I didn't feel like I needed to struggle to come up with small talk or to come up with things to say, or I didn't feel like I was grasping in my mind for that right word anymore. And that was a month and a half after my initial diagnosis. So I think it took me about that long, which I think is actually even quicker than the average person. Right, what you would say probably. Yeah, it's a slow, awful, painful process, and one that your identity is taken from you. And I was the kind of person, I've always been wanted to do journalism, and if you wanted to be a journalist, you have to be able to talk to anyone. And all of a sudden, I was robbed of that, and I would, run into friends of mine from high school who didn't know that this happened, and I just looked really different. Steroids make you look really different, and I acted really different. Another defining characteristic of mine is talking really fast, as you guys know now. And all of a sudden, I was talking very slowly and methodically, and they didn't really understand what had happened. And having to encounter people and having to try to explain this to strangers or to near strangers was a real difficult time, and one that I think everyone who experiences anything that affects the brain, whether it's autoimmune encephalitis or traumatic brain injury, or even people who've read my book who've gone through a really bad breakup say that they felt that fogginess. It's not the same, but I understand, like any kind of trauma, and you kind of feel shell-shocked afterwards. It was more extensive than that. But anyway, so I just wanted to kind of talk about that recovery, because it's an important thing to note, that it wasn't like a month in the hospital and then I'm back. It took a long time. So do you have any questions? Or
had you seen autoimmune encephalitis, or did it present in such a way that you said that you knew it was something autoimmune related, but had you already seen or known about that?
Yeah, I mean, this is really the first time I've seen that type of presentation, but I've seen people present with psychiatric illness, not unusual. The best example is it's sort of called lupus. SLE, when involved the brain, the most common presentation actually is psychiatric, not neurologic, not stroke, not weakness, not chorea or movement disorder, actually psychiatric. And 40% of those people who have lupus, they have anti-NMDA receptor, although different subunit. Remember I said that's usually in R2. And they don't have necessarily to have psychiatric illnesses. But the people who have psychosis or neuropsychiatric manifestation of lupus, 50% they have the antibody in the CSF. And guess what? In those type of patients, recent studies showed, majority of those patients who have those antibody, they have depression, slightly more than psychosis, and much more than people who have neurological complication like stroke. So autoimmune involved the brain is not uncommon, can present with psychiatric illnesses. But she gave us a lot of clues. The initial onset unilateral, then the mood changes. It was multi-stage. That was unique about that disease as compared to other autoimmune encephalitis. It was not just encephalopathy per se. It was multi-phase. Start with sensory, then you have that or the prodromal phase, then you have the psychiatric symptomatology, then she had the seizures, then she had autonomic changes, catatonia, and then after that she would have had central hypoventilation or cardiac dysrhythmia. So I always learn psychiatric symptoms, not uncommon symptoms of autoimmune disease. That's for one. For second, I'm interested also in inflammatory aspect of the pure isolated psychiatric disorders. And there's plenty of evidence, even in people who have classical psychiatric disorders like schizophrenia or bipolar or depression, have a tremendous amount of inflammation in the brain. We wrote about that papers in Journal of Neuroinflammation, from activation of inflammatory cells and so forth. And some of those patients, we think they may have some kind of antibody, although the evidence is weak now, or we need more investigation. But maybe those people with the first episode psychosis, they may have some kind of antibody. Again, still controversial, I must say. But when we did meta-analysis for psychiatric illnesses, I looked for the titers, high titers. It separates usually the normal control from actually people who have first episode psychosis. So again, to sum it up, yes, I knew that can present like that, but I have not seen this. Nobody saw it at NYU. Remember, at that time, she was the 217 case, right, worldwide. And certainly in New York State was the second case probably at NYU, first case at Columbia.
To tell off of what you were just saying, what are your thoughts about the treatment of, or the testing or the treatment of people with depression or psychosis for the antibodies, or for, because there's such a high false negative test result rate or undiscovered autoantibodies, just treating blanketly?
Great question, actually. First, as I said, people with primary or classical psychiatric disorders, schizophrenia, schizoaffective, bipolar, and depression. We reviewed the evidence. And the evidence overwhelming was not happened last year or 2 years ago, more than 10 years. We put it together and we summarized that evidence. It is definitive, and that's documented by pathology. And now I'm collecting a tissue, actually, in New York City from a psychiatric patient who commits suicide. As long as the method of suicide will not alter the brain inflammation, to look actually in a pre-suicidal state. Because what we believe that the inflammatory process in depression and schizophrenia is actually state-related. So when you look at autopsy tissue, often chronic state, you may miss it. However, in acute state, you may see more of the inflammation. Some of studies already done by Dr. Johann Steiner from Germany, who redocument HLA-DR microglia activation similar to those cells in suicide in 6 cases. Reality is, so when I say inflammation, I'm not talking about autoimmune. So that's one aspect. Now, in terms of autoimmune diseases, are we talking about those patients have NMDA receptor or not? There were few reports that out of 100 patients, maybe you find 1 or 2 cases, one of voltage-gated potassium channel, one anti-GAD. We report one case with schizophrenia published. The schizophrenia with anti-GAD responded actually with the low titers, despite the fact that anti-GAD, although that question if low titers pathogenic or not, we treated and the patient really responded to that. Now, the controversy right now in people with the schizophrenia, you may find 8 to 10% of anti-NMDA receptor, different from those receptors. Those antibodies prescribed by Dr. Dalmo has specific criteria. You have to have an IgG, not IgA or IgM. The other studies IgM and IgA. Number 2, it has to be defined by certain method we call transfected cells, and the titers should be 1 to 200 or more. And if that's weak in the serum, then you have to go to the CSF or do 2 other methods, which is staining against brain tissue or neuronal cultures. That's how really defined. So the studies in psychiatric illnesses, a pure schizophrenia, it was mostly IgG and IgM, although some studies showed maybe IgG, but low really titers. Those are not encephalitic, but we don't know if they're really pathogenic or not, because the same study showed in normal control could be 10%. Two papers already in one in JAMA Psychiatric and one just a few months ago in Molecular Psychiatry. In JAMA Psychiatry 6 months ago by Dr. Steiner, he said in normal healthy control, you find 0.4% of anti-NMDA receptor, often IgM or IgA, but not against NR1, consistent with Dalmos findings. However, in schizophrenia, especially first episode, or untreated for at least 6 weeks, he found it close to 8%, 9%. The same authors now present the papers, and Suzanne, Dr. Suda, and myself were in the meeting 2 weeks ago, and now it's going to be published in JAMA Psychiatry to correct the number of normal control. Now he said he found it 10%. Why? Because method now more sensitive, able to define it and identify it more. I'm saying those statistics on you just, there's a lot of variation and heterogeneity in methodology and sensitivity and specificity. But at the end of the day, when I did the meta-analysis, regardless of how much healthy control you're going to find it or not, for the same methodology, if you look at the titers, if you said for people who have titers 1 to 320 or above, then you can find separation between first episode psychosis and between actually healthy controls. So still more needs to be done, more studies to be done, but more than that, I think if there is abnormality of the blood-brain barrier, then those antibodies in this serum become relevant. If they do not make it to brain, they're not really relevant. And I think that's really what happens. Now, you go back to pure psychiatric disorders. Yes, I treated pure psychiatric disorders with inflammatory disease. And one case published in prestigious psychiatric journal, Biological Psychiatry, 4 or 5 months ago. This is a journalist. I attract a journalist for some reason. He's from New York, an editor, 25 years. He's now 44-year-old, 25 years of intractable. I have the slides. I actually could show it in this meeting to show. But 25 years of intractable depression, seen at Mayo Clinic, seen at NYU, seen at Columbia, and locked up at NYU for the last 2 years before I saw him more than 3-4 times. This is a guy who have an IQ of 144, but depression his way to the point he lost his job, about to lose his family as well. So I end up being on any old psychotropic regimen to include transcranial magnetic stimulation. So when I got involved in this patient, to convince the family about ECT, because that was psychiatrist and said they heard about me, so comes, the guy who treated Suzanne. So I came in on board, and I really did not support ECT, I didn't go against it. But the wife, she said, you know what, can you treat first with anti-inflammatory before that? And we waiting 25 years, I could wait 6 more months. Bottom line, you go back, can I rule out low intensity autoimmune inflammatory process of some sort, knowing he had some cognitive impairment? So in that patient, we did SPECT perfusion, and the frontal lobe severely hypoperfused bilaterally. Everything else was really, really normal. The biopsy showed impairment of blood-brain barrier with a lot of lipofuscin of endothelial cells never documented before. We give this patient minocycline, and they get IVIG approval because I have inflammatory process now documented by the brain biopsy. Otherwise, we never get IVIG for depression. This guy off antipsychotic medication, off all antidepressant medication, jogging 10 miles every other day, and so about to go back. We talk about to work about 25 years by 4 prestigious academic psychiatric centers. So I'm not claiming you could treat everybody there. There is a small subset of those patients. We don't know where they are. And the challenge to be able now to have criteria to develop for that small subset of patients that potentially can be benefit. I'm not suggesting everybody have to have anti-inflammatory, but that suggests, if you think about the depression, the same number as epilepsy, 1/3 of epilepsy refractory to medication. Well, guess what? Depression, 1/3, no matter what you treat, you will not get with the treatment. 1/3, they get reasonable response. 1/3, superb response. That's what we get in epilepsy. That's the statistics. Why? Because both have inflammatory process. And just to add more to that, People with depression have higher incidence of cardiovascular disease and have higher morbidity. People with cardiovascular disease have higher incidence of depression. Now, studies being done, I'm trying to participate, how we could prevent cardiovascular disease in patients with depression. And do you know what's common between both disease? We think about this disease, mental disorder, it's endothelial cell dysfunction. That's why they have a higher cardiovascular disease and so forth. And the best evidence of that, the FMD study, flow-mediated study. So with people with depression and have cardiovascular disease, when you do fluid challenge to dilate their brachial artery and to measure ability to dilate, we found out that people who have depression have much less ability to dilate brachial artery following fluid challenge as compared to people who have only cardiovascular disease with no depression. So there's a lot of evidence that endothelial cell damage mediate. And that's probably inflammatory process. And now we know about cytokines elevated, like IL-6 and IL-1. So that's why I'm not against, I'm not a pro or against autoimmune process in a subset contribute to those patients, because we have a lot of evidence of inflammation. But what antibody, what titers, and I think to be relevant, you have to have a blood-brain barrier. But for us to say there's absolutely no role, I think we're not ready yet for that. I'm saying it needs more studies to see which subset of patient had only inflammation versus have autoimmune disease. I tried to be too short here. I'm sorry.
So, Susannah, something that someone in the audience said when we were in New York and you were speaking really, really stuck with me. They said that identifying a physical or physiological cause for your psychosis was destigmatizing for all people with psychosis, or all people with mental illness, because it's. And I think there were a couple thoughts behind that. One is because something that's curable becomes less stigmatized.
Yes.
But also because in the end, it's all just one brain and it's all physical. There aren't really mental illnesses,
Right.
physiological illnesses. So my question to you is, you've been out talking to people all over the world. How do you see your work as destigmatizing being in a state of delusion, psychosis, paranoia?
I think actually, Helen, actually, when we had an event at NYU all together, I think she said it best then, and the idea is the mind and the body are not distinct. They are one, mind and body. And I think that this disease, I'm not even sure, I think the work that the people here from all the way out of town who are coming here, the doctors who are sharing their research, they're the ones who really are doing the work destigmatizing that. Because I think you're right. I think the stigma comes from the fear of the idea of we don't know where it comes from. We don't know what causes it. So it's this shadow. It's this something we can't grasp. It's not it's not a broken leg. It's not something we can kind of point to. It's theoretical, and I think that's really scary. I think that's kind of the source of that. And I think once you show that you tamper with these NMDA receptors, and all of a sudden you become a different person and you become psychotic. And we know exactly what these NMDA receptors right there help to cause psychosis. And I think taking that step and showing that cause and effect in behavior and in the brain, I think that is a step towards destigmatizing mental illness in general. And it's amazing to me there, and I think it still continues, where people do draw a line between organic and mental or psychiatric. And I notice myself doing it too, even of all that I've learned. I notice that when someone obviously had not read my book and introduced me as someone who had a psychotic break. This person has mental illness. They introduced me as that. And I said, no, I didn't. No, I don't. And I noticed myself, I'm like, well, actually, I kind of did. If you took the DSM out and you described all my symptoms, I matched schizophrenia. That is to a T kind of what's there. So what's the difference? The difference is that I was cured and we know the cause. But, on paper, I was the same as, so I kind of found myself doing that, and I was very disappointed, but I think we still have a long way to go, and I think that all the research that everyone's here kind of sharing is helping towards that goal.